Good afternoon, everyone. Welcome and thank you very much for joining today's webinar, Evidence to Life-Saving Action, Public Health Research to Prevent Silicosis, which is being presented by Cancer Council's No Workplace Cancer Project and the Public Health Association of Australia WA branch. So I'm Matt Kavorko from Cancer Council WA, where I'm responsible for coordinating Cancer Council's National Occupational and Environmental Cancer Prevention Project called No Workplace Cancer, and I'm also the Vice President of the Public Health Association of Australia WA branch for 2024. So before we begin, in the spirit of deepening relationships, I would like to acknowledge all the traditional custodians and owners of country throughout Western Australia and Australia. For where I am presenting from, that is the Whadjuk people from the Noongar Nation, and recognise their continuing connection to land, waters and community. And we also pay our respect to their elders and extend that respect to all Aboriginal peoples living and working in this area. And of course, to any Aboriginal peoples who may have joined us online today. So here's the outline of today's webinar. For just a brief background, Australia is the first country in the world to ban engineered stone, with the prohibition having come into effect on the Monday just gone. So that was the 1st of July 2024. So its regulation will protect the health of workers around the country by preventing their exposure to this dangerous product and reducing their risk of silicosis and lung cancer. So research conducted at the Curtin School of Population Health has really been instrumental in generating the evidence used in advocacy efforts by unions and peak health organisations that led to this critical action to protect the public's health. So in addition to implementing the world first ban, back on the 10th of May this year, the Work Health and Safety Ministers also agreed to the Model Work Health and Safety Crystalline Silica Substances Amendment 2024, which essentially means that from 1st of September this year, amendments to the Work Health and Safety regulations will provide for stronger regulation of work with all materials containing at least 1% crystalline silica, including engineered stone, across all industries. So today, Renee will outline her research that helped inform the government's decision, and then we'll discuss the process of translating that research into action. So I'll talk about this from a Cancer Council perspective, and then Owen will provide the union perspective. During this webinar, we encourage you to ask any questions you may have. So to submit your questions, please use the Q&A function, as the chat function is disabled at the moment. That's located at the bottom of your screens. If the question is seeking clarification about a particular point that's being talked about, we'll try our best to address it during the presentation. Otherwise, we should have about 15 minutes to address any questions during the Q&A session at the end of the presentations. Additionally, we would appreciate your feedback after the webinar. An online evaluation survey will be sent out, and we encourage you to complete it just so we can improve our future webinars. So with the housekeeping out of the way, it's my privilege to introduce you to today's first guest speaker, Dr. Renee Carey. So Dr. Renee Carey is a senior lecturer in the Curtin School of Population Health. Her research focuses on exposure to occupational carcinogens, the future burden of disease resulting from those exposures, and then the effective interventions to reduce exposure and the effect that has on future disease. So over to you, Renee. Thank you very much.
Thanks, Matt, and thank you for the opportunity to speak here today. So as Matt said, I'm going to give you an overview of some work we did a year or two ago now that looked at occupational silica exposure and the future number of lung cancer and silicosis cases that might result from that exposure. And also going to talk a little bit about the public health and policy response and how we went about translating the research. But again, as Matt said, Matt and Owen will both touch on that a little bit more. So I'm sure by now most of you are aware of silica, silicosis, engineered stone, but I'm just going to start with a quick overview and then I'll move on to what we did in our report. Okay, so what is silica? So crystalline silica is a naturally occurring component of a lot of building and construction products, things like sand, stone and concrete, and it's also used in the manufacture of building products, so bricks, tiles, glass, etc. Silica dust, or respirable crystalline silica, is the substance that's produced when these products are cut, drilled, grinded, crushed, or otherwise disturbed. And those particles are generally less than 10 micrometers in diameter, so about 100 times smaller than a grain of sand. So they can be inhaled and deposited deep within the lungs. So as a result of this, we know that silica dust is a particularly aggressive and lung-damaging dust. Occupational exposure to silica dust occurs in a wide range of industries, mining, construction trades, and then the manufacturing of those products such as glass and ceramics. Back in 2012, we did a survey and we found that about 6.6% of the Australian workforce was exposed to silica dust at work. That exposure was particularly common among our miners, so 92% of the mining workforce were exposed, and our construction workers, so 80% of the construction workforce were exposed. Since then, government infrastructure spending has increased, and so there has been an increase in the number of workplaces with silica exposure, particularly places like tunnelling, and that wasn't included in our estimates. And also there was this huge increase in the use of engineered stone, which we didn't consider back in 2012. So it's likely that those numbers have grown in the last 10 years. So there'll be more people exposed at work now. We know that exposure to silica dust is linked to a variety of health effects: silicosis, lung cancer, autoimmune disorders such as systemic sclerosis and rheumatoid arthritis. When that silica dust is inhaled, it deposits and accumulates in the lung tissue, resulting in inflammation and scarring. And the most common lung disease that's associated with silica exposure is, of course, silicosis. So this is a progressive and irreversible condition, and basically the healthy lung tissue is replaced by fibrotic tissue, making it really hard to breathe. Currently, we don't know how common silicosis is in Australia. We're getting a better idea as time goes on, and we also know that the incidence is rising due to the introduction of that engineered or artificial stone. So engineered stone, also known as manufactured artificial stone, various brand names. It's commonly used in kitchen bench tops, and it's known to be a particularly potent source of silica dust. So it typically contains up to 95% of crystalline silica, and that's compared with natural stone materials, marble and granite, which can contain around 2 to 40%, anywhere in there. So what this means is that those who are working with engineered stone are at particularly high risk of silicosis and other silica-related disease. We know that the first report of silicosis from engineered stone came from Italy in 2010. First cases in Australia and the US were in 2015. And since that time, there's been a re-emergence of silicosis cases in our workers here in Australia. So historically, what we were seeing the incidence of silicosis decreasing. We're now seeing a huge increase in numbers, and we're also seeing a greater number of accelerated silicosis cases, so greater aggressiveness, shorter time period between when we're exposed and when we're getting disease, and also disease occurring in younger workers. And this has been attributed to the introduction of engineered stone. This massive increase in the incidence led to the Australian government establishing the National Dust Diseases Task Force, and they were tasked with informing a national approach to the prevention, early identification and control of occupational dust diseases in Australia, particularly focusing on silica and silicosis. Their final report was released in June 2021, so 3 years ago now, and that had a number of recommendations that were looking at addressing the risks of exposure to hazardous dust and an immediate focus on engineered stone. So one of their recommendations was that we look at a ban if nothing had changed by July 2024, and obviously that's happened since then. So that's kind of where we were when we looked at writing this report. Obviously more has happened in the policy space since then, but for now I'll talk you through what we did, the research we did, and then what those further steps were. So while the National Dust Disease Task Force was doing their report, we were commissioned by the Australian Council of Trade Unions to produce our research report that looked at the future number of silicosis and lung cancer cases that might be caused by exposure to silica dust at work, and also to look at how many lives could be saved by undertaking various control measures, including banning engineered stone. And that report was really designed to be used in responding to the task force and Safe Work Australia's recommendations. So what we did, we aimed to estimate the future burden of lung cancer and silicosis cases that might arise as a result of contemporary occupational exposure to silica. It involved a number of steps. So firstly, we looked at the number of future lung cancer cases that might result. We then extrapolated that to the number of future silicosis cases. We then estimated the number of lung cancers that we could prevent through various control measures. And then finally, we looked at the number of silicosis cases we could prevent. So we needed to start off with an estimate of how many workers were actually exposed to silica dust in 1 year. We used 2016 as our year. That was the most recent census data at the time of the report. So we used data from the National Prevalence Survey that we did in 2012 that I mentioned earlier. And then we added in some data from the census about particularly how many people were employed as engineered stone workers, because we knew that those workers weren't covered sufficiently in that early study. So we estimated that 584,000 Australian workers were currently exposed to silica at work. We know that's probably almost definitely an underestimate. We know we haven't covered tunnel construction workers, for example, but it was the best we could do on the data we had available. There is no register of silica-exposed workers in Australia. So then we used our method, the future excess fraction method, or the FEF method, to look at how many future lung cancers would result from that exposure over the lifetime of those workers. So it's a method that's based on the lifetime risk approach, and it estimates the proportion of cancers over the lifetime of those who were exposed in 2016, which would result from that exposure. And you can see that there in dark blue. What it requires is the number of workers who were exposed in 2016, which I've just described, a risk estimate for the relationship between exposure and cancer, which we got from the literature, an estimate of future person years at risk, so we use life tables to calculate that, and then an estimate of future lung cancer incidence, which we looked at from AIHW data. So we had a cohort of 18.7 million Australians who were of working age in 2016. And we first looked at how many lung cancers they were going to develop over their lifetime. We found that they would develop just over 1 million lung cancers in their lifetime. And we then looked at how many of those cancers would occur in our workers who were exposed to silica as a result of that silica. And we found that 10,390 lung cancers, or about 1% of those cancers, would occur in exposed workers as a result of their silica exposure. We then looked at the number of, or the ratio of lung cancer to silicosis cases in previous research, applied that and estimated that around between 80 and 100,000 workers would develop silicosis in addition to those lung cancers as a result of their exposure to silica. So what we wanted to do then was to look at what the potential impact of some ways to reduce that exposure might be. We looked at it both in terms of overall silica exposure, so all industries, particularly mining and construction, and then we focused in particular on engineered stone and some interventions around that exposure. Based on the hierarchy of controls, so we start with elimination and substitution as the most effective controls, move on down through engineering and administrative controls, which look at isolating people from the hazard and changing work practices, and then on to personal protective equipment, which we generally think of as the last resort in protecting our workers. So if we look first at silica exposure as a whole, and we're looking at the number of lung cancers we could prevent here. So the top bar shows the baseline. That's how many lung cancers we would get from current exposure to silica if nothing changes. So that's our 10,390. And then the other bars show the impact of various interventions. So the pink bar is the number of lung cancers we predict would happen. The blue bar is the number that we're preventing by that intervention. So if we look at reducing construction exposure to silica dust in the construction industry, and we're reducing that to the level in the general population, it's not possible to completely remove it, but we're looking at saving over 6,500 lung cancers by doing that. Probably not feasible, but it's kind of our best case scenario. Then more specific controls. So if we had dust suppression on all our construction and mine sites. Those water trucks, we'd save around 1,400 lung cancers. If we instituted wet cutting on all concrete, we'd save around 640 cancers. And if we restricted access to areas around mine site crushes, we're saving around 750 lung cancers. A similar story here if we look at silicosis. Pretty much the only thing is just the scale's changed. Again, at the top baseline, so how many silicosis cases we're expecting from current exposure if nothing changes. Reducing exposure in the construction industry is saving around 50,000 of those cases. Dust suppression around 11,000. Wet cutting of concrete saves around 5,000 silicosis cases. And restricting access to mine site crushes saves around 6,000 silicosis cases. What I should also note here is that all of the interventions we modelled started with the assumption that there was already some level of those controls in place on work sites, and we looked at what would happen if there was 100% compliance with those controls. We then looked at interventions which targeted engineered stone in particular, and this graph here shows us the number of lung cancers that we've avoided in pink and the number of silicosis cases that we would avoid in blue. So the first thing we looked at was what would happen if we had a ban on engineered stone. And we found that's going to save 100 lung cancers and around 770 silicosis cases over the lifetime of those engineered stone workers. Our engineering controls, so if we have on-tool dust extraction, if we have wet cutting methods for all engineered stone work, and if we have ventilation, we're saving between 30 and 50 lung cancers and 210 to 370 silicosis cases. On-tool extraction was the most effective, you can see there. And then if we set up exclusion zones around stone cutting areas, which is a really simple intervention to put in place, we're saving 20 lung cancers and 130 silicosis cases. Again, some baseline level of controls was assumed to be already in use, and we looked at 100% compliance. And we also assumed, importantly, that workers were wearing well-fitted respiratory protective equipment alongside those controls. We know that the controls alone aren't sufficient to reduce exposure and that they need to be used alongside respiratory equipment. Similarly, we didn't model the use of respiratory equipment alone because that's known to not be completely effective in reducing exposure as a standalone measure. Just quickly, there are a couple of assumptions we made. So it's an estimate of the future burden only in those who were exposed in 2016. Doesn't look at cancer and silicosis cases for those who weren't exposed in that year but had been exposed either side, so in the past or could be in the future. So we're not taking account of exposures over the entire work history, but what we are doing is we're assuming that there's a normal distribution around that exposure, so that some of those who were exposed in 2016 were exposed in the past. Some of them would still continue to be exposed in the future, and some of them have only just been exposed for that short period of time. We also used a best estimate of exposure, which was based on an amalgamation of data. As I said, there's no comprehensive database of silica exposure available. We've made some assumptions around our cancer incidence. We've based projections on demographic change only. We don't know what cancer trends are going to do in the future. And then we use that ratio of silicosis to lung cancer because we don't know how many silicosis cases there are in Australia. So as a result of that, we think we've probably come up with a conservative estimate or an underestimate, but the best available estimate based on the data that we have. So I'd like to just talk a little bit about what happened next, and then I'll hand back to Matt and Owen to continue. So the initial purpose, as I mentioned, was to feed into the NDDT and safe work processes. So in response to the National Dust Diseases Task Force recommendations, Safe Work Australia produced a regulation impact statement, and that was in 2022. And that looked at 5 different options for controlling the risks of silica exposure. They looked at the predicted costs of those options to industry and to government, and they looked at how many cases of silicosis they'd need to avoid in order to break even in an economic sense. So just quickly, these are the options here, things like raising awareness, national licensing framework, air monitoring. And briefly, we've got the results of the economic analysis here, and that shows us that even the most stringent options only need to save around 48 silicosis cases over the next 10 years. We showed that a lot more cases could be prevented over the lifetime of those workers. So banning engineered stone would save us 770 silicosis cases, or around 100 cases every 10 years. Simplified comparison, but just showing us how much more we can do and how many more lives we could have saved beyond what they considered. So our report was used to feed directly into the consultation process. We used the findings as the basis of our own submission to the consultation. The findings were used by others in their responses, including the ACTU and Cancer Council. And in addition, we got a lot of media attention from a lot of different outlets, and still are receiving media attention now. We co-authored articles for the conversation and shared our report with a variety of policymakers, including Tony Burke. Alongside what we were doing, a huge collaboration of organisations were involved, and many of these organisations cited our report findings in their materials. So the ACTU was really proactive in bringing together a range of organisations, some of whom are shown here on this slide. And that was really important because it meant everybody was on the same page and providing the same message, looking for that same end point. Big union response as well. So the CFMEU, for example, vowed that they would stop their workers from using engineered stone if it wasn't banned. There was a Silica Dust Kills campaign, there was petitions, and we also saw these real life stories of people who were affected, which really, really showed how big the issue was and how it was just ordinary, regular people who were affected by the issue. Story on 60 Minutes and a huge range of other stories. So at last count, our report had been cited in over 900 media stories, potential audience of 14.5 million people, and probably other stories aren't captured in that statistic. Big retailers got on board. So Bunnings announced that they were going to stop stocking engineered stone last November. That was followed by other industries, other stores, including IKEA. And then we saw this batch of zero silica engineered stone that started appearing. Most of the major stone companies have come out now with zero silica options. So they contain alternative raw materials, things like recycled glass, still mixed in with those resins and pigments. We don't yet know how much safer they are than engineered stone. Still health issues associated with the resins, but removing that silica is a great step. And then ultimately all of that led to our outcome. So a ban on engineered stone was announced by the Ministers for Work, Health and Safety in December last year. And it means that the use, supply, manufacture, processing and installation of all engineered stone with a silica content of greater than 1% is now banned as of the beginning of this month. It doesn't apply to repair, modification, removal or disposal of engineered stone that was installed prior to the ban, and there is a framework being developed to deal with that. And there are also transitional arrangements in most states. So in WA, we've got a 6-month phase-in, meaning you can work with engineered stone until the end of the year, provided you entered into the contract before the end of last year. Some further regulations also around silica coming in September, and that's going to deal with the wider issue of silica as a whole, beyond engineered stone. So we're looking forward to seeing those come through. And just quickly before I finish, just looking at the model that we used, can be applied to a lot of other diseases, exposures and interventions. So we have previously used it to look at future cancers from occupational and lifestyle exposures, as well as how many cancers could be prevented by intervening to reduce diesel exhaust. There are some limitations to what it can do based on the data we've got available. So in this case, for example, we couldn't look at autoimmune diseases from silica because we just don't know how many cases there are. But lots of opportunities as well, and hopefully we can continue to have an impact on health and occupational health with this research. Thank you again. I do want to quickly acknowledge the ACTU and in particular Deb Vallance and Liam O'Brien, as well as my co-author Lynn Fritchie. Thank you, and I'll hand back to Matt.
Brilliant. Thank you very much for that, Renee. That's fantastic. Really setting the scene regarding the problems associated with silica dust exposure in the engineered stone industry in Australia, and really providing a nice overview of your research. And it's really great to see the impact that that's had and the pickup that that got in the media, having 900 plus citations, 14 and a audience of 14.5 million. That's amazing. So well done. So now I'll touch on the translation of Renee's research into action from a Cancer Council perspective before finishing with just 3 key points about what makes good translational research. So just to give you a little bit of context, the No Workplace Cancer Project, that's our national occupational and environmental cancer prevention project. And through this project, we aim to reduce the incidence of cancer attributable to exposure to carcinogens in the workplace and the broader environment. And then we secondly aim to communicate the importance of reducing exposure through known control measures. So we do that through 3 main ways. First being advocating for and promoting awareness of evidence-based policy reform. Secondly, developing relevant resources that provide information on key workplace cancer risks, effective control measures and legal obligations. And then third is promoting policy-focused messages and resources via social, print and online media platforms. So currently the project has 4 priority carcinogens as well as a few other carcinogens to round out the portfolio. But since I've been with Cancer Council, which has been since November 2019, respirable crystalline silica has really been our #1 priority. And to help tackle this issue, we established a silica working group back in 2020, and our #1 policy priority was to achieve a national ban on the importation of engineered stone products. So important to note that we are a national project, even though I'm based in WA. I help to coordinate our health promotion and our policy and advocacy efforts regarding occupational cancers and exposure to carcinogens in the workplace at that federal level and across all Australian states and territories. So why were Renee's figures so important from a Cancer Council perspective? So primarily the modelling done by Renee and Lynn, that provided us with the best available estimate of the future number of lung cancer cases caused by silica dust exposure in the engineered stone industry. It's important to note that no estimate existed prior to this report. So it really provided important evidence regarding the impact of silica dust exposure from engineered stone products and occupational exposure to silica dust more broadly, such as in the mining industry and construction, as it relates to lung cancer specifically. So thereby showing that the problem is wider than silicosis and then helping to strengthen that silica dust and that lung cancer connection. And this is quite important because media attention really focused on silicosis for a number of reasons and very much rightly so. But being Cancer Council, we're primarily concerned with the lung cancer aspect of this, obviously. So we have the cases of engineered stone related silicosis, but we've not yet seen the cases of engineered stone-related lung cancer, again, for multiple reasons, but primarily because of the cancer latency period. So essentially, that's the period between exposure to a given carcinogen, so silica dust in this case, and then the development of disease, the onset of symptoms, and then subsequent diagnosis, which is often decades long. So therefore, the numbers in this report were something that we could actually easily point to and say, hey, this will cause lung cancers in the future if we don't do anything about it now. So it clearly demonstrated what the impacts would be if government continued to not act, if they failed to address these risks right now. So in other words, it highlighted the problem very clearly. And then following on from this, it clearly demonstrated the reduction in future burden of diseases if the government did act now. So it offered tangible and actionable solutions. So we could take this directly to the ministers responsible for work health and safety and say, look, this is how many workers' lives can be saved if you take action and ban engineered stone now. As you can imagine, this evidence really formed a key part of our justification and our argument when advocating for a ban. So what did we do with the research findings? Primarily, we wanted to share these findings with the people who are responsible for making decisions. And we did this a few different ways. So first off, there was submissions to key consultations. So Renee touched on the Safe Work Australia's consultation regulation impact statement, managing the risk of respirable crystalline silica at work. That was back in August 2022. And importantly, that did not include a ban on engineered stone as one of those regulatory options. So we were definitely putting forward the case saying that, yes, they should be considering it as a first option. There was Lung Foundation Australia's National Silicosis Prevention Strategy 2023 to 2028, and their accompanying National Action Plan, which is currently being finalised. And then lastly, there was Safe Work Australia's public consultation on the prohibition on the use of engineered stone, which was in April last year. And that's obviously a very key, that was a key consultation where we could directly address the matter of a ban. Last year, we also met with Minister Johnson. So Melissa Ledger, who's our Director of Cancer Prevention and Research at Cancer Council WA, Professor Lynn Fritchie, an occupational epidemiologist and who co-authored the report with Renee, Tracy Bentz, the then president of the Australian Institute of Occupational Hygienists, and Owen, of course, from Unions WA, and myself. We met with Minister Bill Johnston, who was at that time the WA Minister for Industrial Relations and his Chief of Staff at Parliament House, where we highlighted these figures. We sent at least 16 letters to the Ministers for Work Health and Safety across Australia, which cited Renee's figures. In particular, we sent letters to the ministers responsible for work health and safety for the Commonwealth, WA, New South Wales, Victoria, South Australia, Queensland, Tasmania, and ACT ahead of their meeting on the 13th of December. And those letters, they're actually accompanied by a joint statement from unions, public health organisations, including Cancer Council Australia and Public Health Association Australia, as well as work health and safety specialists. So this was a significant meeting because this is where they actually considered and decided whether to adopt the Decision Regulation Impact Statement's recommendation for a prohibition on the use of all engineered stone, irrespective of its silica content. And then there's also that media aspect as well. So soon after the Safe Work Australia public consultation regarding the prohibition, when that closed in April 2023, the Australian Council of Trade Unions organised a joint media release, Calls Intensify for a Ban on Lethal Engineered Stone, which Cancer Council Australia co-signed alongside the ACTU, the CFMEU, the Australian Institute of Occupational Hygienists, and a few academics. Of course, Cancer Council Australia also published a media release immediately following the announcement of the engineered stone prohibition, welcoming that, saying that it's protecting the lungs of thousands of Australian workers. And then the other aspect of this is the social media posts. So we have done at least 17 plus posts across the Cancer Council Federation's Facebook, Instagram, LinkedIn, and X profiles. And even though the ban has been announced and is now implemented, we still use Renee's research and stats to continue to raise awareness of the harms caused by silica dust in key industries, well, from engineered stone, but then also in key industries more broadly. And we do this on key dates such as World Day for Safety and Health at Work, which is on the 28th of April, as well as dates like Tradies National Health Month, which is in August. So this isn't a summary of all our policy and advocacy and awareness raising activities regarding silica dust exposure, but only what directly cites Renee's report. So if we were to include all our other activities that we've undertaken the last 4 or so years that used evidence from Renee and her colleagues' previous research, namely the Australian Work Exposure Study, which is a very important study to give us prevalence of exposure to occupational carcinogens, then this would at least be 3 to 4 times as long. For those of you who are more visual learners, here's a few screenshots of what this looked like. And then what are some of the key takeaways from this experience and what makes good translational research? And there's obviously a lot that could be said here, but I've chosen just 3 key points. First of those being clear relevance and applicability. It should address real-world health issues that the needs and the priorities of the community and the population it serves. And this ensures that the research outcomes are relevant and they're applicable to real-world settings, right? So essentially it answers that so what question. We want actionable findings, right? So this research should generate feasible, practical, implementable, and acceptable findings that can be translated into policy and practice to improve the public health outcomes. So in other words, it's policy relevant research. And then thirdly, and this is a really important point that Renee touched on as well, it's that interdisciplinary cross-sector collaboration, right? So good translational research will often involve collaboration between different disciplines and different organizations that share a common goal. So for example, this can be experts and researchers from disciplines such as epidemiology, occupational hygiene, public health, health promotion and medicine, non-researchers such as unions, not-for-profits, law firms, peak professional bodies, and then of course, incorporating consumers and people with lived experience of the health issue and the disease. And to that point, I think it's critical to emphasize that this was the result of a collective effort and that we, or Cancer Council, were only one piece of that overall puzzle. So the other members of the consortium, or the Silica Dust Alliance, which Renee touched on, all did an incredible amount of campaigning and advocacy. So it was a really encouraging and a rewarding partnership to be a part of and to contribute to. And it's particularly important to acknowledge the work of the Australian Council of Trade Unions and their affiliated unions who led the charge, advocating for the protection of our workers, and then sharing the stories of those who are directly impacted by silica dust exposure and silicosis, so that you could have those lived experience, those stories that accompany the data and the projections and those estimates, right? And with that, I think that's the perfect segue to our next speaker, Owen Whittle. So Owen is currently the Secretary of Unions WA. He was elected in 2021. He's previously served for 8 years as the Assistant Secretary, leading a major campaign for occupational health and safety law reform, resulting in the successful modernisation of work health and safety laws here in WA. Owen was a previous member of the Ministerial Advisory Panel into Work Health and Safety Reform. He's been a member of the Work Health and Safety Commission since 2014, so he's one of the Commission's longest serving members, and is a non-executive director of WorkCover WA. Just a quick reminder to please pop in any questions into the Q&A chat function, and we'll address these after the presentation. So I'll stop sharing my slides and across to Owen.
Thanks, Matt, and I'm pleased to kind of join with you all here today to talk about this important issue. I'm a bit more slack than the previous last two speakers, so you'll just won't get a PowerPoint slide from me, and we'll just get my reflections. I'm going to give a kind of a union and workplace level reflection on this campaign. Matt and Renee are the smart two. It's really my job to kind of take their good work and, for lack of a better word, kind of weaponize it in terms of getting change at both a workplace level with union delegates and health and safety representatives, but also in the kind of string of regulatory committees we sit on with state and federal governments, kind of deciding work health and safety policy. And I think it's firstly important to frame this win as both a success and a big failure of public policy and public policy making. It's most definitely been a major success in that, against some very entrenched opposition, we've managed to go from absolutely nothing to a ban in just a number of years. It's also been important as part of kind of a wide variety of civil society organisations, researchers, unions, public health organisations banding together and fighting decisively for strong action and a change of outcome. And we have achieved this quickly, especially when you compare it to kind of the slow action on things like vaping and smoking for a long time. And Australia has become the first country to institute a ban on this product, as it's been talked about earlier. But it's also been a monumental failure in public policy because we've known of the dangers of silica and silica dust for a very, very long time. It should not have taken as long as it did for the penny to drop for both industry and regulators that this product was very dangerous and that it was causing harm. We went from a strong understanding of how we can safely, or more safely, cut stone and deal with kind of dust in workplaces, to all of a sudden kind of completely forgetting that when we moved from cutting products with kind of 10 or 20% stone through, and then moving to cut products with 95% silica. The first eradication of silicosis for coal miners and stonemasons was a major public health win. And we found ourselves just kind of absolutely back to square one. And that was just absolutely negligent in the extreme that these workers attracted silicosis. And I'll come back to that a little bit later. Renee and Matt have outlined the research, but what I found interesting is that the longer this campaign went on and the longer we worked together to try to prevent harm in the artificial stone industry, the stronger and more decisive the actions that needed to be taken to prevent harm became. during the very early stages of this campaign, and as the first few cases of silicosis trickled through, the conversation was really centered in a space of we need to have PPE when cutting stone. It needs to be cut while wet. We need kind of dust suppression. We need masks. It was very, very much concentrating on that kind of lower focus controls. Then we moved into a space where we started to talk about, well, now we just need to lower the percentage of silica in these products. It's not about banning artificial stone. It's about, oh, well, if we can move it from 95% silica to 80% silica, well, maybe that'll be a public health win. But what we found as the kind of knowledge of this research grew and as more and more research came out, we actually didn't see industry embrace change or move towards protecting workers at the scale they needed to. And that's really where the conversation went from just controlling the risk to banning the product outright. And as that pressure to change built, and as the change became apparent, we saw some good work occurring, both in research and in activism. WorkSafe in WA in about June 2021, published some outcomes of a study that they ran in relation to the 2 different inspection campaigns for artificial stone. And the second round of an inspection campaign in 2021, this is years of media, this is years of this being out in the public and the dangers of this product being well known. WorkSafe still found that there was very little local exhaust ventilation in artificial stone workplaces. They found where it did exist, it was not maintained and was completely inadequate for actually ventilating the workplace. There was no dust extraction attached to hand tools and cutting equipment in the majority of workplaces. There was an inadequate amount of respiratory protective equipment, and where it was used, workers weren't trained to be able to use it, or it wasn't being used correctly. And that a lot of these workplaces who were using wet cutting, were recycling the water for the wet cutting without filtering it of contaminants first. So you actually had a slurry that was with very high levels of dust and silica in the slurry being used, which actually probably was worse than not using wet cutting at all. They weren't taking basic, easy and affordable steps to reduce the harm and exposure from the use of their product, despite what the research was saying and despite the growing evidence base. WorkSafe also found at that time that still 25% of their testing showed that stone fabrication workers were exposed above the maximum exposure standard, and 33% of installers were exposed above the exposure standard. And an additional 40 and 33% were exposed above an actionable level for the review of controls and more action to be taken in workplaces. And an alarming 66% of assay lab workers were exposed above the exposure standard. Industry was really thumbing their nose at us, the research and the groups collectively working to make workplaces safer from artificial stone. WA then moved to be the first state in the country to move from X-rays to low-dose high-res CT scans to screen for harm for artificial stone, and ran this little study where they went and found 90 workers who'd previously just had chest X-rays and been cleared of any harm whatsoever, and gave them the CT scans. And they found that half had health concerns or lung damage that were not identified when they'd only been assessed by an X-ray. And they found 7 new cases of silicosis in those 90 workers who'd been previously completely cleared of any harm whatsoever. This was extremely frightening, and I suppose just goes to Renee's point about the large amount of undiagnosed cases that there will be in industry in relation to silicosis. And we also have to remember that large portions of this workforce was an overseas-based workforce in Western Australia on temporary work arrangements, who I have absolutely no doubt were sent back to their country of origin with silicosis, large amounts of silicosis, and have had to have managed that in their countries of origin without compensation or without support for that health needs. So as we saw this level of harm grow, unions then, in weaponizing the research, started to target individual suppliers, but also going after Bunnings and IKEA and those that were selling artificial stone to the do-it-yourself and residential construction industry. CFMEU really led the charge on targeting that, leafleting out the front of Bunnings and IKEA. And we started to see those companies, after really only a week or two of standing out the front of a Bunnings, say that they will eradicate the product and move to not sell it to do-it-yourself customers or whatsoever. And throughout this campaign, we really had to deal with kind of a lot of vested interests from industry that were using this kind of affordable cheap product and making a lot of money out of it. We had to overcome a lot of concern regarding the kind of drop in exposure standards and some of the evidence that we were bringing forward in relation to kind of eliminating the harm from this product. We saw the resources industry were particularly vocal. I heard in many closed-door meetings that lowering the exposure standard was impractical, and the usual kind of fear-mongering that will come from the cost of such an implementation. Of course, that completely forgot the costs to the public health system and workers of having to deal with, hundreds of cases, if not thousands of cases of silicosis around the country. The only contested vote I've witnessed in my years on the Work Health and Safety Commission was with the CCI and the CME and WA both voting against reducing the exposure standard for artificial stone against all the evidence. So it shows you a bit where that vested interest will lie. And it was only a few months ago we saw Dale Alcock criticising the ban of artificial stone that was upcoming, kind of saying the risk analysis was flawed. Kind of strange comments from someone who's patron of an asbestos diseases charity. And it was notable that we managed to win this despite the opposition. And I think that was because of the evidence base that was produced by researchers such as Curtin University and others, but also the kind of coalition of groups who came to work together to make it happen. We're still seeing those kind of crocodile tears of kind of producers and businesses of the product about the ban. And I'll go back to my earlier point about how this was kind of a failure of public policy. And that's that when we moved from 20 or 30% silica content of products to 95%, and we completely forgot both the regulator and industry that silica can cause harm. It should have been acted on early and often, and I think there was probably some blind or willful ignorance to the fact that occurred. These companies had workers cutting, kind of not dry cutting 95% silica products in homes around the country for years and years and years. And when the evidence emerged that it was causing harm, they still continued with it and barely moved in terms of their control measures. We've seen in WA, we know that WorkSafe has issued hundreds upon hundreds of improvement notices to the artificial stone industry. We know what improvement notices are. It's just a notice to lift standards to the minimum legal compliance level. So WorkSafe were hundreds of improvement notices just asking businesses to reach minimum standards and minimum legal enforcement levels. But being asked not to blatantly break the law isn't really a penalty in terms of the harm that this has occurred. And I think there's been a great failure of enforcement mechanisms and regulators and public policy that there actually hasn't really been any real repercussions of industry out the other end of this ban. They knew it caused harm. They should have known it caused harm. They got hundreds of notices to just meet minimum standards, but there hasn't been a single prosecution of any artificial stone company out the other end of this. And instead of complaining about the artificial stone ban, they should really count themselves lucky that they haven't been dragged through the courts for hundreds of prosecutions from our safety regulator. They've escaped far too easy out the other end of this. They've escaped far too easy for the level of harm that they've inflicted on ordinary workers who relied on their employer to put safety mechanisms in place. And actually our regulator has completely escaped any kind of visibility for the fact that they have not pursued any prosecutions or charges based on this either, and have monumentally failed, I think, working people of this state out the other end. So this is kind of something that I think from Unions WA and Unions perspective that we need to kind of turn our minds to, that with all this evidence, with everything that happened, our regulator still couldn't bring prosecutions and hasn't really actually held the industry to account aside from the ban and just doing the things that they should have already been doing when they first started using artificial stone. There's some important next steps on this. Kind of Matt and Renee, I think both mentioned diesel exhaust. I think this campaign and these groups coming together has led to a proper examination of other contaminants and other exposure levels. We've seen more action on welding fumes, and we're kind of diesel exhaust is now an open question, an open conversation for the harm that's occurring. And I think there's some real logical next steps that kind of unions, researchers, public health organisations kind of work together to kind of continue this momentum to make sure that we're achieving some change in some other areas. Might leave my comments there. Thanks, everyone.
Brilliant. No, thank you so much for that, Owen. You touched on a lot of good points there. Honestly, I mean, yeah, like you said, to emphasize, just to pick one of them, silicosis is completely preventable. It's an old disease where we know what causes it, and it shouldn't be happening in 2024. And the fact that it is, and that the engineered stone industry were, given ample opportunity to, up their game. That's a really key point. In terms of just like, and this Owen was saying that in WA there was hundreds and hundreds of infringement notices. This was replicated in all states and territories around Australia. In New South Wales, it's in the thousands, those infringement notices. I mean, if you look at their stats for silicosis cases, from 2017 to 2018, there was 9 cases reported. That jumps to 107 cases in 2019 to 2020. And then they start recording the deaths as well from silicosis. So in 2020 to 2021, there was 7 deaths, then 10 deaths, then 9 deaths. Now there's been 8 deaths in the 2023 to 2024 period. That's only up until the 31st of March this year, to go alongside 99 cases in this that financial year as well. So all up, they've had, in the last 7 or 8 years, 441 cases of silicosis that have been confirmed, and then 34 deaths as well. So, which is just massive. So we've got a couple of minutes left just for a few questions. If anyone wants them, feel free to put them in the Q&A. I don't think there's any questions in there now, but just to get the ball rolling, I think one of the key points that we should touch on is compensation, and whether these people who have developed silicosis are currently being or are currently seeking compensation. So that one's definitely for Owen, I reckon.
Thanks, Matt. Yeah, I found it really interesting, the discrepancy between the number of silicosis cases that we know exists and the amount of workers that have been compensated for that harm. We know that there's at least 50 that have been reported in total, although probably, as we keep on saying, that the real number is going to be in the hundreds, if not a lot higher than that. I understand that there's barely a handful of workers that have actually applied for the workers' compensation scheme and been compensated. And that discrepancy has alarmed me for quite some time. I think we generally have been terrible at having systems and structures in place that make it affordable and easy for workers to get compensated for occupational disease. We've also got some laws that for a long time have stood in the way of compensation. And now the WA government's got a bill in the parliament at the moment in relation to dust diseases, particularly focused on asbestos, but it covers all dust diseases, that eliminates all the once and for all rule for compensation for dust disease. And essentially what that means is that for a long time, we've had workers who develop a minor or a non-fatal version of a dust disease do not go forward and get compensated, and they hold off to develop the fatal form of the disease or of a disease before seeking compensation. Because if they got compensated at that early stage for a debilitating but not fatal disease, they wouldn't be able to come back when they have the fatal, and the difference in that compensation is quite significant. WA has finally caught up with the vast majority of the country and taken that step to get rid of that once and for all rule that will allow workers to come back. But what they haven't done, and it's a real shame, and this is going to, a lot of workers are going to die without getting this next bit before it is eventually done, is they're not compensating for gratuitous services, and that is the limb of compensation that will allow workers who provide care services to either kind of partners or kids with disabilities to be compensated for the value of those care services. That's very significant, particularly when you're looking at the age cohort of those diagnosed with artificial stone silicosis. They are workers in their 20s, 30s, early 40s, as opposed to the traditional occupational asbestos exposure, which normally presents in workers who are of an older demographic. So it's a great shame that the WA government's only doing half of what they need to actually provide some justice in terms of compensation. Half they're doing is great, but there's still a long way to go.
Thanks for that, Owen. Just going to quickly throw to Renee just about, I guess, the international perspective, and if you've had any interest from overseas, because this is not an issue that's solely based in Australia. We know in New Zealand, they're currently looking at us and advocating for a ban. And yeah, if you have any thoughts around that.
Yeah, so I'm not fully across the situation internationally. As you said, I know that New Zealand is starting to push for a ban now. Also, US, mostly California, they're not looking at a ban, but they're looking at stronger regulations. Personally, I haven't had anyone approach me looking for further kind of research, but we did publish an article in The Conversation on Monday, and we've had a huge readership, and lots of that's coming from the US and Canada. So obviously it's an issue that's really gaining momentum internationally. So good to see that they're interested, and hopefully it translates.
Yeah, absolutely.
Yeah.
Yeah, so you might get a tap on the shoulder in due course.
Yeah.
We've only got a few more minutes, and no questions have popped up. Is there any final things you want to touch on, Renee or Owen, before I close things up? No, all good.
Nothing from me.
Owen, any final thoughts?
Well, to continue my critique of regulators, I'll throw one last one in, if we've got a few minutes for me to fill. Unionists are worse than academics or anyone else. If you give us a space to fill, we'll just carry on until someone closes it on us. The other part of the silicosis cases that aren't connected to stone benchtops has, of course, been just dust exposure in the resources industry. About 10 years ago, WA moved to eradicate the mine health surveillance scheme in Western Australia for mine workers, which gave them a pretty comprehensive medical and had that data then held and reported to the regulator. It's kind of been telling since that was eradicated that we've now seen, a handful of silicosis cases reappear in the mining and resources industry. There was strong warnings from public health professionals that this would happen at the time that was eliminated, and I think the Barnett government pulled that back. Professor Fritchie, of course, who was involved in this bit of research with Dr. Carey, was very public and did a lot of media kind of calling on those warnings on that. So it's been interesting to see 10 years later that everything she said would happen has come true. It's almost like she knew what she was talking about, but was ignored by decision makers, regulators, and the government. So we've had that action on it. Artificial stone, dust more generally needs a lot more work, particularly in the resources sector.
Yeah, thanks, Owen. Good. That's a good point. There's definitely a lot more work to be done in this space. So just to close, I'm going to just share the final slide with everyone. There's no other questions. So with that, on behalf of Public Health Association Australia WA branch, on Cancer Council WA, we would like to sincerely thank our presenters, Dr. Renee Carey and Owen Whittle, for their time and sharing their thoughts and their expertise, and for everyone for tuning in today. For those colleagues who were unable to join us online, we'll be publishing a recording, so please keep an eye out for that. And then just lastly, the Australian Public Health Conference 2024 is being held in Perth at the Pan Pacific Hotel from 17th to the 19th of September. It's hosted by the Public Health Association of Australia, and this year's theme being high value public health in a complex world. In a complex world. And early bird registration is open up until the 24th of July, so please be sure to check it out. Keep an eye out for our evaluation survey. We would appreciate any of your thoughts. Thanks again, everyone, and enjoy the rest of your day.